Electrolyte imbalances can occur in healthy people as a result of changes in fluid intake and output. These imbalances are usually mild and are easily corrected. Severe electrolyte imbalances with actual losses or retention of specific electrolytes are life-threatening and can occur in any setting. This is a two-part lesson. This will be an interactive lesson and you will be prompted when to participate. People at greatest risk for severe imbalances are older patients, patients with chronic kidney or endocrine disorders, patients who are mentally impaired, and patients who are taking drugs that alter fluid and electrolyte levels. Remember, in electrolyte basics we discussed sodium, potassium, calcium, chloride, magnesium, and phosphorus. In this lesson, part 1 of electrolyte imbalances, we will only be discussing the sodium and potassium electrolytes. Click on the sodium and potassium buttons and able to review content related to the imbalances of those electrolytes. After reviewing the sodium and potassium electrolytes, click on the arrow below to continue with this lesson. Remember, sodium is the major cation in the extracellular fluid and maintains extracellular fluid osmolarity. First, we are going to discuss hyponatremia. This is when the sodium level is below 136 milliequivalents per liter. Common causes are provided in Table 13-5, page 181 of your textbook. Some of these causes can be wound drainage, use of diuretics, NPO status, hyperglycemia, and many more that are listed in this table. Deep tendon reflexes will be assessed looking for a decrease, whether it's normal, whether they're brisk and excessive, or is it with clonus. The pathophysiology results in reduced excitable membrane depolarization and cellular swelling. The depolarization depends on high extracellular fluid levels of sodium being available to cross cell membranes and move into cells in response to a stimulus. Hyponatremia makes depolarization slower so that excitable membranes are less excitable. The osmolarity of the extracellular fluid is lower than that of the intracellular fluid, causing water to move into the cell, leading to cellular swelling. Even a small amount of swelling can reduce cell function. Larger amounts of swelling can make the cell burst and die. This is known as lysis. Click the arrow below to continue with this lesson. Collaborative care will include an assessment. You will check for cerebral changes, depressed or excessive activity, or both. This is a result from cerebral edema and an increased intracranial pressure. There will be sudden onset of confusion in older adults and may indicate that they are experiencing hyponatremia. Neuromuscular changes consist of general muscle weakness. You want to check the deep tendon reflexes and also check respiratory effectiveness. Cardiovascular changes include rapid, weak, thready pulse. They may have decreased blood pressure with severe orthostatic hypotension. This will be opposite when hyponatremia occurs with hypervolemia. GI will have increased motility. They'll have nausea, diarrhea, and abdominal cramping. They may have hyperactive bowel sounds. Potential nursing diagnosis may include disturbed thought processes, excess fluid volume, or risk for injury. And overall goals are to restore serum sodium levels to normal and prevent complications from fluid overload. Click the arrow below to continue with this lesson. The other sodium imbalance is hypernatremia. Sodium level is over 145 milliequivalents per liter. High serum sodium levels can be caused by or can cause changes in fluid volumes. Table 13-6 on page 182 of your textbook lists common causes of hypernatremia. A few of these are kidney failure, fever, infection, hyperventilation, and many more that are listed in the table. The pathophysiology of hypernatremia is: as serum sodium level rises, a larger difference in sodium levels occur between the extracellular fluid and intracellular fluid. More sodium is present to move rapidly across cell membranes during depolarization, making excitable tissues more easily excited. This is called irritability, and the excitable tissues over-respond to stimuli. Also, water moves from the cells into the extracellular fluid to dilute the hyperosmolar extracellular fluid. So when sodium levels are high, severe cellular dehydration occurs. Click the arrow below to continue with this lesson. Collaborative care includes an assessment. With the nervous system, they'll have altered cerebral function. With normal or decreased fluid volumes, they will have a short attention span with agitation or confusion. Manic episodes may occur if the sodium continues to rise. With fluid overload, they will have lethargy, drowsiness, and stupor, possibly a coma. In the skeletal muscle, they will have muscle twitching, leading to progressive weakness. Deep tendon reflexes are decreased. In the cardiovascular system, they will have decreased contractility. Pulse and blood pressure may be normal, above normal, or below normal, depending on the fluid volume and rapidity of occurrence. Hypernatremia and hypovolemia, they will have an increased pulse rate, decreased peripheral pulses. They may also have hypotension and orthostatic hypotension. Hypernatremia and hypervolemia also will include slow to normal bounding pulses, full and difficult to block peripheral pulses, distended neck veins, even in an upright position, and an increased blood pressure. Nursing diagnoses include excessive fluid volume, decreased cardiac output, risk for falls, impaired memory, and/or potential for pulmonary edema. Overall goals are to prevent further increases in sodium, decrease sodium levels, prevent hyponatremia, and prevent dehydration. Click the arrow below to continue with this lesson. Remember, we discussed potassium being the major cation of the intracellular fluid. Hypokalemia is a potassium level below 3.5 milliequivalents per liter. This can be life-threatening because total body potassium inside cells is 98%, and a minor change affects all body systems. Actual potassium depletion occurs when potassium loss is excessive or when potassium intake is not adequate to match normal potassium loss. Relative hypokalemia occurs when total body potassium levels are normal, but the potassium distribution between fluid spaces is abnormal, or it is diluted by excess water. The pathophysiology of hypokalemia is a result of low serum potassium levels increasing the difference in the amount of potassium between the fluids inside the cells and fluids outside the cells. This increased difference reduces the excitability of the cells. As a result, the cell membranes of all excitable tissues, such as nerve and muscle, are less responsive to normal stimuli. Some of the common causes are listed in Table 13-7, page 184 of your textbook. A few to mention are diuretics, diarrhea, vomiting, wound drainage, MPO status, and many more that are listed in the table. Click the arrow below to continue with this lesson. Collaborative care will include an assessment. During the history taking, you will check age related to decrease in renal function, illnesses, urine output, drug use, diet,